Okay, you guys can look over that RSI decision tree. Make sure you guys also really do look over this before you guys go into your RSI recorded lecture. I believe this slide is also in the RSI recorded lecture, but this kind of gives you kind of an easy to follow algorithm here. Okay, so let's talk about this, right? Let's talk about worst case scenarios, all right? You are assuming that your patient's going to need intubation and things look okay, right? You have started this at the time that you guys have made patient contact. You're looking at your patient, right? You might have already got a millipotty. You know that you have a good millipotty, maybe a class 1, class 2. They're not like a short neck. They don't have any kind of past medical history. Everything's looking good, right? So you try RSI, and you find yourself unable to intubate. Okay, so what's the first thing you guys are going to do? You guys have sedated and paralyzed this patient, and now you cannot establish an airway. Okay? What's the first thing you're going to do? I'm going to tell you right now, the first thing you guys are going to do is breathe. Take a deep breath. Stop. Okay? You are in that situation. It's time to use that focusing that you guys have, right, to your advantage. Use fear to your advantage. Stop and breathe. Okay? Let's think about this. Let's talk about this for a second. While you guys are talking, don't forget to oxygenate your patient. Right? Let's get the BVM back on, and let's see, at the very least, that we can control this dude's or this patient's airway to get an oxygen saturation above 90%. Okay? Let's start there. All right? Let's get the bag on and maintain the oxygen saturation of 90%. Okay? If we have an oxygen saturation, if we have RSI this patient, and we have an oxygen saturation of above 90% while we are bagging, we are no longer in that crashed or failed airway. We are in the difficult airway scenario. Okay? Right? We are able to control the bagging with 90%. Yeah, it's frowned upon that you guys just paralyzed and sedated this patient, but at least you're able to maintain the oxygen saturation of 90% with the bag. Okay? If not, and we are still seeing this patient go down and down and down, we cannot get this patient's oxygen saturation to maintain at 90%. You guys are in a failed intubation scenario. Okay, it's now time to think about whipping out your supraglottic, your backup airway, or just crack your patient. Okay, when we're talking about a critical patient, we definitely want all hands on deck. Okay, we want to bring another medic with us. At the very least, bring another medic with us. Whenever I'm dealing with a difficult patient, I might take 2 or 3 riders with me. I own the airway. I do that. Everybody else kind of works whatever they got to do on the way to the hospital, right? So difficult airway. Okay, let's say that we are able to maintain 90% oxygen saturation. Okay, your patient is sedated, all right, from your RSI, sedated and paralyzed. You missed the first try at the tube. Okay, now what? Okay, you have gone in there with the laryngoscope. Let's say you're using your favorite Mac blade or Miller blade, whatever you guys, whatever your flavor is. You guys tried a tube, and it just didn't work. So what are we gonna do now? Okay. So whenever we're talking about multiple attempts, okay. Again, anytime that you stick the laryngoscope into the patient's mouth and that blade touches tissue, that is an attempt. Okay? You pull that blade out, you're done with that first attempt. You better be changing something. Okay? Maybe go from that Mac to the mill. Maybe increase the size of your macro mill or decrease the size of the macro mill. Okay? We are going to we're going to try to reposition the airway. We're going to try to use the elm and burp mnemonics, which we're going to come to here in a sec. All right, so we're going to try to elevate to manipulate, or we're going to try to the burp, which is backward, upward, rightward pressure. We're going to take our hands, our free hand, and we're going to start manipulating the actual trachea itself. And burp stands for backwards. We're going to go backwards first, upwards second, to the right third, and a little bit of pressure. And that usually kind of opens up the airway for you while you're manipulating the actual trachea itself, for that you guys to actually see the vocal cords. But it doesn't always work. We're going to talk about that again here in a minute. Okay? So we failed. Right? We failed. We have sedated, paralyzed and sedated our patient. We went in there for the first intubation attempt. It didn't work. Let's pull it out and let's rethink some stuff while we're doing that. Let's start bagging, maintaining an oxygen saturation at 90%. If you guys start bagging, right, and you guys are able to maintain that oxygen saturation at 90%, breathe, guys. Take your time. You're only in a difficult airway. Okay? You're only in a difficult airway which your patient is maintaining, and you are doing it for them. Okay? So you guys got a lot of time, as long as you guys are maintaining that oxygen saturation above 90%. Okay? You guys go in for a second attempt. All right? Let's say it doesn't work. Okay? Again, we need to change something. Okay? We need to change something. The big one is we better change the blades. And second, and more importantly, we need to change providers. Okay? It's time for somebody else to take a look. You guys are done. You guys have had your 2 attempts. Let somebody else take a look at it. At this point, if you want to have another medic take a look at it, that's fine. But really, I mean, if you think that your basic or intermediate that's on scene can drop that King or LMA, maybe that's the way to go at this point. So at least we know that we are securing the airway, and then your little basic or EMT intermediate has just saved your license because they were able to get the airway that you couldn't get after paralyzing and sedating your patient. Okay? Hallelujah. Everything's good. Let's think about patient care. It's not about egos. Okay? Let's get it done. Okay? If we are unable to intubate within 3 tribes, we need to move to our rescue airway. Period. Okay? Whether it be a King, whether it be an LMA, whether it be cracking. All right? If the saturation drops below 90% with the BVM, we need to go to the failed airway. We are not going to attempt another intubation. We're going to go straight to our failed airway. Or we're going to go straight to the failed airway algorithm, and we're going to use our backup airway. So again, the failed airway, not able to maintain 90% or greater on the BVM, and unable to intubate after 3 attempts. When we're talking about backup, it must be available. Okay, it needs to be out and open, and it needs to be already lubricated, properly lubricated, right? So this is going to be something for your intermediates or basics to do, right, on scene, or somebody else that has a set of open hands, right? Hey, I'm going to try to get this intubation. I want you to get me my LMA or King. I don't care which one. Just get it lubed up and ready to rock, right? Be familiar with those supraglottics and LMA guys, okay? I know you guys are here to learn paramedicine, and you guys might not want to practice during your free time dropping a King or LMA, but I'm going to strongly suggest you guys do that, right? When you guys get back in the lab, if you guys have quote-unquote free time, you guys should be getting your hands on that equipment and dropping those supraglottic airways, okay? Remember, those supraglottic airways are easy to use, right? And they can save your butts. Okay, just because we can do something doesn't mean that we should be doing something, right? When we're talking even with patient advocates, if you guys intubate somebody, we can't really guarantee that tube is going to come out, right? We have dropped an airway on somebody, and that tube may never be removed from them. Okay, and if it does get removed, they've at least bought themselves a 4, maybe 5, 6 day stay in the ICU, just kind of learning how to swallow and kind of getting their voice back. All right, where if we do a LMA or a supraglottic King, right, it doesn't cause that much damage, and there's not a lot of rehab after that. So again, make sure that you guys are being patient advocates and doing what is best for your patient. All right, crike is always, always, always a last resort. It is not considered a backup. I'm going to say that again. Cricothyrotomy is a last resort. Okay, it is not a backup. All right. So this is okay. Again, I fear crikes. All right. This is the last procedure I ever want to perform as a paramedic. Okay. I've never done it. I've seen 2 attempts while I was an intermediate. One went fantastically well, and the other one, I guess the best way to put it is it didn't go as good as the first one I saw. This is where you guys are really going to try to do really good patient advocation. Okay, you're going to take all 3 attempts, still following the procedures. You do 2, another provider does 1. We might even try to drop an LMA or King as well after that 3rd attempt. And then if we can't get that LMA or King, man, we have no choice. We're going to go straight to that crike. Okay, and then there's certain situations where you guys might have to go to the crike straight off the bat, right? And talk about a high stress scenario. Just breathe, guys. Okay. Again, I don't want to do a crike, but even after paramedic school, we've had opportunities to practice our crikes, specifically with my with the service that I was with, and I don't feel comfortable with it, right? But man, I'll do it if I have to. I'll tell you that much right now. Okay. But it's something that I really don't want to do. How do we prevent the failed airway? Is by assessing and anticipating the difficult airway in the first place. Again, it starts at patient contact. Don't make the patient worse. Okay. If we can get away with BVM, get away with BVM. Okay. Do good BVM skills. Make sure that you guys are. If you're by yourself, make sure you got a good CE technique. If you have an extra set of hands, have one person hold that mask to the patient's face and the other one bags. That way we can get that way we can guarantee a good seal. Okay. And then when you guys are bagging, make sure that you're bagging at appropriate rates. Okay. Make sure that you guys have that patient on end tidal, and make sure you have pulse ox. Make sure that you have them in the sniffing position. Maybe use some airway adjuncts as a NPA and OPA along with your bagging. Right, we can do a lot with just our basic skills. Okay, sniffing position. Sniffing position is the best position for our patients. Okay, we want to be able to raise the head so that the tragus of the ear is at the same level as the patient's sternal notch or collarbones. Okay, the sniffing position, like you guys are going out to sniff some roses on a bush. That's the position we want. That takes a lot of elevation, guys. Okay, that takes quite a bit of elevation, at least 3 to 5 inches on most adults of padding behind the head. Okay, and again, obviously, please remember that this is for non-trauma patients, right? This is where we still can perform that head tilt chin lift, where if we have a trauma patient, we just got to do the jaw thrust as best as we can in order to try to maintain that open airway. Okay, so ELM stands for external laryngeal manipulation. This is actually done by most of the time done by the actual provider that is performing the intubation. So you have your laryngoscope in your left hand, right, and you're kind of looking around, and you're manipulating the actual trachea while you are looking down the gullet of the airway, right? That's what ELM stands for, external laryngeal manipulation. With that also goes the burp mnemonic, which is backwards, upwards, rightwards pressure. All right. The intubator actually manipulates the larynx by moving the thyroid cartilage with the right hand during direct laryngoscopy. Okay. The problem with this is you just lost a hand. Okay. And it doesn't always work. And really what it's supposed to do is just kind of manipulate the larynx in order for you to see the vocal cords. And then you kind of maneuver the laryngoscope in a way so that image stays open so that you can take your hand away in order to grab the tube. Okay. Burp can be good with another medic, where one person's actually looking in the airway and another medic is actually performing burp, because we don't train our basics or intermediates on how to do that. So they know that it's backwards, upwards, rightwards pressure. But still, you don't want to go in there for that failed attempt, right? Or you don't want to go in there for that attempt and be manipulating the airway by moving around the larynx. And you see that beautiful view of the vocal cords, right? And you know that the only reason why you have that view is because your freehand is creating that view for you. And knowing that you have this view now, and when you let go in order to get that tube, that view is going to go away, and more than likely you're not going to get it. Well, you have just wasted an attempt, right? It's more than likely you're not going to see that beautiful picture the second time you go in there. Okay. Burp. What is burp? Backwards, upwards, rightwards pressure. This can be done and hopefully done by your assistant. Okay. It moves the glottic into a better position, and it adds cricoid pressure. Okay, so it kind of really line up the airway for you guys pretty good. Okay, so again, when you're holding the larynx while you guys are holding your voice box, push it to the right and down to the neck, and up towards the chin. Then hold steady. Okay, that's how you do it. And more than likely, you guys are going to see those vocal cords every single time you do that. Oops. So there's the two different two different views, one with cricoid pressure and one without. It's not 100% perfect, but it's better than nothing, right? Angle of the head is very important. You guys can look over the slides yourselves, okay? The guys can look over the head positions with that. Remember, we want the tragus of the ear lined up with the actual level of the sternum notch or the collarbones themselves. Okay, you guys can check out those as well. Excessive hyperextension is bad. Okay, we don't want to hyperextend the neck too much. It does kind of give us, it could technically help us with intubation a little bit when we're doing a hyperextension. And really what I mean by that is sometimes, like if I'm at the head in the airway chair in the back of your ambulance, I would actually pull the patient's body up so that the head is actually dangling off the top of the gurney, and then start to look. So I'm technically kind of hyperextending the neck, but I'm improving my view. And then once I get that, once I actually see the tube go through the vocal cords, at that point I would readjust my patient, make sure that I have still a good patent airway, and readjust the airway so I don't have a kink in the tube when we're actually bagging the patient. There's the sniffing position there for you guys. Okay, that is the most optimal way that we want that tube to be in. That is a beautiful open airway for you guys. Okay, this lady here, you can see all the pillows it took to elevate her. Okay, so this is, I believe, called the RISE method. I don't think RISE actually stands for anything, but it's basically a ramp that you build for your patients, especially if they're bigger, all right, if they are bariatric. They actually kind of sit this patient up as best as they can, and they build a ramp with pillows and blankets in order for them to be able to lay her back down comfortably, that the patient's actually comfortable, and we now have the tragus of the ears lined up with the sternal notches. Good intubation angles. Make sure that we're doing a good angle, right? That we're kind of coming in from the left and manipulating up to the right. Or I'm sorry, coming in from the right, manipulating up to the left. Always think about your view, okay? Again, we don't have the luxury of being in a controlled setting in EMS. Sometimes just based on the patient position themselves, and you might not be able to really do anything about it at times. You just need to kind of try to get that view as best as you can. Get down on your belly, get down on your knees, right? I've intubated a patient when I was sideways, kind of laying on my right side. Just do what you can in order to try to get a decent view of the airway. Okay. Confirmation. I'm not going to spend too much time on this because I'm going to tell you how to confirm your tube, right? Direct visualization, lung sounds, and end tidal CO2, period. Okay? direct visualization, lung sounds. You guys, for documentation, you guys can document that you have seen misting or condensation in the tube. All right, but the gold standard is end-tidal CO2. And I know when I was on the streets before I left the streets, we had a protocol in place where you guys were supposed to always have end-tidal, right? You should always have end-tidal when you have a advanced airway in. But the doctors needed to sign off before we moved the patient from our bed to their gurney, and then from when we got them from our gurney to their bed and the patient was situated, we'd have the doctor confirm again and sign our charts that that we did not dislodge the tube upon moving the patient. End-tidal CO2 is your friend, guys. I talked about end-tidal a little bit before in AMP. I'm not going to get back on the soapbox, but once again, it is the greatest invention given to EMS since the dawn of our existence. Okay, securing your